Yeah, is my slide visible, Dr. Balla?
Yes, it is visible, Amit.
Yeah, so I'm going to talk on combined surgery, that is phaco trap. No financial disclosures. So why do we do a phaco trap? Because one surgery helps in both clearing up the central vision loss from cataract and in controlling the peripheral vision loss from glaucoma by lowering the IOP. The possibility of worsening cataract following glaucoma surgery alone is eliminated, and after glaucoma surgery, subsequent cataract surgery may induce inflammation, causing glaucoma surgery to lose its effectiveness or even fail. So, phaco trap provides early visual rehabilitation of the patient with cataract and glaucoma and reduces the risk of early severe post-operative pressure elevation. It also provides long-term reduction of IOP and decreases the need of glaucoma medications. So, what are the indications of this triple surgery? That is the phaco trap plus IOL. A patient with cataract and a glaucoma patient who is having failure to achieve target pressure by medications. There are issues related to compliance and adherence to medical therapy. There is an adequate IOP control but significant drug-induced side effects. There is a borderline controlled IOP with a disease progression or near maximum medical therapy and is moderate to advanced glaucomatous damage. So these are the indications to do a combined phaco trap. So what are the techniques for phaco trap? You have the single site technique and the twin site technique. Single site technique, basically the phaco and trap is done through the same site. It has less surgical time. Twin site is phaco is done through a separate clear corneal temporal incision as the first step, followed by trap at the superior limbus as the second step. It involves more surgical time. But when we look at single site versus the twin site group had 1 to 2 millimeter more IOP reduction and required less post-operative medications. But although the difference was not statistically significant. So coming to a video on basically the two techniques, the single site and the twin site. I'm just going to show this video. It's taking some time to load. My internet connection is really unstable today. Still, the video is not running. Dr. Valla, can you see the video running?
No, Amit.
No, it's still loading. Yeah. Yes, this is a case of trap plus phaco. It's a triple procedure. So in this, what very important is taking the corneal stay suture or the superior stay suture and then marking the conjunctival flap. So usually when I do a phaco trap, I mark it at 3.5 to 4 millimeters. So you mark your conjunctival flap and then do a subconjunctival dissection. Cut at the limbus in one go and do posterior subconjunctival dissection as much as possible so that you have a diffuse posterior flap. So you have to do this on either side of the curtain of the conjunctival flap and also behind as much as possible. Try to identify the bleeders and cauterize only the bleeders. Don't generalized cautery should not be done because that will lead to shrinkage of the scleral flap once you do the scleral flap. If you are using any antimetabolite with the 5-year mitomycin, count the number of sponges which you are going to use it. You should have your titrate your own holding period of this mitomycin and the concentration of the mitomycin. After the holding period, when you take out these sponges, always count and take out. You don't want any of the sponges to be missed. Usually what I do is because there's conjunctival chemosis, when I wash out the antimetabolite, so I iron it out and again I mark my scleral flap to 3.5 millimeter. I always do a triangular flap, but you can do a triangular flap or a rectangular flap whichever you're comfortable with. So I mark my triangular flap 3.5 by 3.3 millimeter and then lift up the apex of this triangle. So you hold the apex of the triangle and lift it up in the air and with the help of 15 number blade, just touch the cutting edge of the 15 number blade at the junction and you will see that you will get a uniform flap. But the key to this is that you should always stretch the apex of the flap superiorly into the air. Then this is a twin side phaco surgery, so I shifted temporarily and then you do start with a normal phaco surgery. So this was a case of complicated cataract with secondary glaucoma with a small pupil. So as a cataract surgeon and a glaucoma surgeon, you need to plan out how you're going to manage this small pupil. So I did a cyanocolysis. I achieved a bit of mydriasis, but this was not sufficient for my case. So then after removing the clear corneal incision, I thought of using a Malugin ring. Now this Malugin ring, it sits on the iris plane and it makes your phacoemulsion procedure more safer. So you can see that the distal scroll is engaged into the pupillary border and the two scrolls are engaged. So and then the Malugin ring is extensor scroll is engaged. These devices lie at the pupil, so your phaco is not disturbed. The routine phaco, whatever you're used to, you can do it. But what I advocate to do is to do a small, slow motion phaco emulsification. So managing the small pupil as a glaucoma surgeon is very, very important because we come across a lot of patients with this small pupil. So now you can see the DEXIS being performed. An adequate 5.5 millimeter DEXIS is performed. Once the DEXIS is completed, Then basically you have to do a hydrodissection. Again, you have to be very careful that you should not overdo the hydrodissection. You should do a gentle hydrodissection and then proceed with your FICO. My preferred technique of FICO is basically a stop and chop technique in which I make a central trench, divide the two hemispheres into two, separate the two hemispheres once the central trench is made. Then each hemisphere is further subdivided into 2 to 3 small pieces, and then these are emulsified and aspirated into the FICO probe. Once this is done, the cortex wash is done with the help of a bimanual. I always prefer a bimanual because it gives an easy access 360 degree. And after the cortex wash is done, whatever PC polishing is needed, that is to be done. And this IOL is ejected into the capsular bag. So this is the procedure of phacoemulsification with IOL implantation in a combined surgery. Once this is done, the malignant ring is taken out with the help of a bimanual technique. You can just disengage it from the pupillary border and then withdraw it with the help of an injector or with the help of a forceps, whatever you're comfortable with. So once your phaco is done, then you again move superiorly. Now lift up the triangular flap and see whether adequately it is the blue-white junction is exposed or not. Now you can prepare the internal ostium with the help of a 11 number blade, an MVR or a Kelly sponge, whatever you're comfortable with. If I'm using a 11 number blade or a MVR, I make a 2.2 by 1 millimeter internal ostium, and a broad-based peripheral iridotomy is done with the help of a Lim's forceps and a 1 hour Caesar. Earlier, what I should do is intermittent apical suture is used to be placed with the help of a 10-0 ethicon. But now what I do is I place a single releasable suture at the apex, and that's all. So it all depends on how you titrate your surgery. So what usually for beginners I recommend is 1 apical suture intermittently and 2 releasable suture on either side. Now how do you what I do is I pass the suture into the clear cornea in front of the limbus, and then perpendicular to the limbus from the clear cornea into the scleral flap, and then from the scleral flap into the intact sclera. So whatever loop is created over the scleral flap, now this loop, the 4 throws are passed over this loop, and you can see once the 4 throws are passed, you can tighten it. The advantage of releasable suture, it provides a tight AC, and post-operatively you can titrate your blood by releasing the releasable suture and keeping the AC adequately formed. And this is the advantage. The conjunctival suturing is very, very important. You should always take the episcleral suture at the limbus so that, and you put interlocking sutures with 80 Vicryl. You don't want to make sure that you take the episcleral anchoring suture, because if you don't take that, then with the late movement, the blood conjunctiva will get retracted posteriorly, the blood will get retracted posteriorly. So the key is take a proper suturing. The next, there's one more video I'm showing on a basically single site surgery. Dr. Balla, am I audible?
Yeah, you are audible. Can you?
Yeah. So this is a small video clip of a single site surgery in which a trap and phaco is done to the same site. Now, how does this differ? Basically, we being most of the surgeons are temporal phaco surgeons, so it becomes a bit difficult to do the surgery to the single site. But there are surgeons who are superior phaco surgeons, and for them it is a very good surgery, because it is more relaxing for them because they are used to the technique which they are doing it. So, as I told earlier, also a superior rectus suture has to be taking into consideration that you get a nice anchoring. 3.5 millimeter is marked on the conjunctival flap. But this is very important. You should not do a blind procedure, because you should always measure the flap and do it, because in the future, if the trap fails, you know what was the site, where was the site, and how much conjunctival dissection you have done, so that you can do a repeat procedure also if needed. So you see, in one go, I've cut at the limbus, and with the closed Caesar, I'm going in the subconjunctival space and trying to open it so that the tissue gets affected, and there is as much as posterior dissection as possible, so that whatever aqueous egresses out, it is going posteriorly, and we have a diffuse posterior bleb. After that, as I told earlier also, the cauterization part is very important. You identify the bleeder and cauterize only the bleeders. If you do excessive cautery, once you make the triangular flap, you can see that the flap gets shrinked, and there's a unevenness in the size of the flap. So again, mark the spiral flap, as I told you, 3.5 by 3 millimeter, and again triangular or rectangular, whatever you are comfortable. This is very important. You should know the depth of the incision when you are taking. It should be more than half the thickness of the depth. And if at all there is any ooze when you are doing this conjunctival flap or a scleral flap, you can always cauterize it gently, or you can just use a wet sponge to pressurize it, and the bleeding gets stopped. You can see I am lifting up the apex of this triangular flap, and I'm just cutting the cutting edge of this 15 number blade at the junction. you always make sure that you tell your assistant whenever your view is off, just touch this wax sponge at this junction so that you get a nice view and you just touch the cutting edge of this 15 number blade. So wax sponge plays a very, very important role. In this case, mitomycin was used, but it was not used intraoperatively. It was not used after making of the congenital flap. Before I started surgery, I injected 0.1 ml of mitomycin, that is 0.02 milligram subconjunctivally as much posteriorly as possible superiorly. And after holding period of 2 minutes, I started with my trap surgery. So you can see I'm making the scleral flap. Sometimes the sclera is not same in every tissue, in every eye. So every eye you might not get a good flap, but sometimes you might get an uneven flap, but you have to be prepared with it. But make sure that you don't press the apex much because there should not be any cheese wiring or a buttonholing of this flap. So once this scleral flap is done, then you do the two side ports. Because I use a bimanual, I want two side ports. But if you're using a coaxial, you can just use one side port in the non-dominant hand through which you're going to pass the second instrument and stabilize the cataract when you're doing the fake wave resolution. So here I'm doing two side ports with the help of a 21 gauge MBR. These are the two side port incision bit I made. Now with a 2.2 millimeter keratome, I'm entering into the anterior chamber. So I'm doing a 2.2 millimeter entry because my phaco sleeve which I'm using supports the 2.2 millimeter incision. And now sodium hyaluronate is used throughout the surgery. So the rexis is done and the phacoemulsion is being performed to the superior side. So this is called as the single side phaco surgery, wherein the trap incision and the phaco wound is in the same site, and that is the superior side. So as I told you, prefer technique of stop and chop. Make a central nice deep trench, separate the two phases, and inject the IOL. Now with the help of a Kelly sponge, I'm making the internal ostium. So again, the internal ostium, you can shape it in the L shape or a mushroom shape. So whatever you are comfortable with, you will always try to titrate your own skills and try to make sure whether you want to do an L-shaped opening of the internal ostium or a mushroom-shaped opening of the internal ostium. So this is a 1 millimeter punch which I'm using it, and I'm trying to cut the trabecular meshwork. So you can see that throughout the AC is formed, the sodium hyaluronate is injected. This helps, you should not over inject the sodium hyaluronate because if you over inject, there might be high risk prolapse. So to avoid high risk prolapse, you just adequately inject sodium hyaluronate and maintain the AC. A broad gauge iridotomy is done now with the help of the suture. And as I told you, nowadays what I use is only a single releasable suture. So you have to titrate your surgery. Whatever is comfortable in hand, you have to go ahead with that. So the technique of releasable suture, I have already explained it. So pass into the clear cornea parallel to the limbus in front of the limbus in the clear cornea, then perpendicular to the limbus. You can see now from the clear cornea into the sclera, into the scleral flap, and now from the scleral flap into the intact sclera, I'm going to pass it. So this is very,
Amit,
very
can
important.
You conclude? Amit,
yeah.
You just
yeah. So thank you, and that is what I wanted to say in my surgery. Thank you.